put 11 p.m, but we've already talked about this actually. So 30-year-old patient, foreign body sensation, painful and red right eye. So with that sort of presentation, what sort of conditions are we suspecting? Foreign body sensation, painful red eye.
Abrasion.
Conjunctivitis.
Yeah.
Sometimes dry eye can present a sort of foreign body, can't it?
Yeah.
Or foreign body.
Foreign body.
Um,
And the last one.
Ulcer, corneal ulcer.
Yeah. Also. Okay, fine. So what sort of questions do you ask to try and differentiate between those diagnoses?
Mechanism of injury, if it's a foreign body or abrasion.
So if there's a trauma, basically, it's some sort of scratch, or was there an accident? In terms of foreign body trauma, obviously the most common thing we get is grinding. So it's really important to ask about goggles or not. So a lot of them wear goggles and it gets in somehow. I don't know how it manages, but if they're wearing their goggles, it's less dangerous actually, because it's usually taking a weird indirect route to get in. I'm sure they're lying most of the time.
Sometimes they claim to have been nowhere near crime.
Yeah. So when they're not wearing goggles and it goes straight into the eye, there's a risk of that it's a penetrating eye injury. So you just need to be a little bit wary with those cases where it's gone straight in. Any sort of mechanism that's quite violent, you need to be aware that it might not just be a surface corneal foreign body. They'll have that foreign body sensation and they might have something to scrape out, but they might also have a hole going through the cornea, so you just have to be wary of that. Okay, so if they haven't had trauma, what else? What other sort of questions do you ask?
When did it start?
Past history as well.
Yeah, when did it start? Yeah.
Has it got worse? Better?
Yeah. What about for ulcers? What sort of questions do you ask?
Contact lens wearer.
Contact lens wearer is really important. Contact lens wearers get really bad. I've raced through the rest, didn't I, a bit. So this picture up here are the posterior synechiae. So all these little bits are attached to the lens behind it. It's hard to see, but in 3D you'd see the iris looks like it's being pulled back. And that's just because it's so inflamed that it's just wanting to adhere to stuff. So that's, if you see an irregular pupil like that, that's pretty certain of the diagnosis, to be honest. Whereas in acute glaucoma, the pupil's usually round or oval, like this, and it's quite hazy. That's, if you see that, you don't even need to look on a slit lamp. You know that's acute glaucoma, really. It's pretty typical.
It should be in a lot of pain.
A lot of pain, vomiting, might be confused. They sometimes get delirium. It can be really quite extreme. The general side of the effects of it.
Does she come in as a medical patient for that?
I don't know. This is just from.
What would you, if you get acute glaucoma here, what would you do?
So we'd treat it here. So you want to get the pressure down, basically.
Yeah.
So you give them a drug called Diamox or acetazolamide, which they also use in neurosurgery.
Right.
What that does is it stops the eye producing any fluid. And then you give every antihypertensive drop that we have in the cupboard. So things like timolol, latanoprost, all of that stuff, chuck that in. You also want to give them steroids because it's obviously inflamed. So just steroid drops. You can give them a drop which called pilocarpine, which makes the pupil small, and that can break the attack. Because the problem is that the pupil's got stuck on the lens, so trying to make it come in can break the attack. You can also try simple things like massaging the eye, pressing on the eye, trying to get the iris to move off. I've never seen that work. Or get them to lie down flat. That makes the lens fall backwards. That can break it apparently.
Do they have to be admitted? Or do they go?
It really depends. You can, if they come first thing in the morning, and we're in clinic, for example, we can usually keep them in for the first few hours and then discharge them once it settles down, especially if it settles down quickly. If we're struggling and they need lots of Diamox and then even need mannitol, which when you give mannitol, which is a hyperosmotic, again they use it in neurosurgery, they need to be monitored, their heart needs to be monitored whilst they're on it, and also they need to usually stay in overnight because there's a risk of collapse. So we often keep them in. But the best thing you can do is get the pressure down with Diamox IV and then take them around to the laser room and put a little hole in their iris, which bypasses the blockage. If you can do that, then you've sorted the problem really. And then later down the line, you might take their cataract or their lens out and create a lot more space. Yeah. And when you do the laser in one eye, you always do the other eye as well, because inevitably there are risks in the other eye, so you always do both eyes. That's good. Okay, so we talked about how to differentiate between abrasion and ulcer. It's the colour, and ulcer's whitish, and it's called an infiltrate. And so at 11 p.m, we touched on this. What I need to know on the phone is the size of it, basically, and also whether there's a thing called a hypopion. Because if it's less than 1 millimetre and it's small and you're pretty sure it's an ulcer, then I can say just give them whatever antibiotic drops, siloxane, and then I'll see them first thing in the morning. But if it's bigger than 1 millimetre, we should really come in. Different juniors will have different rules for themselves. Just let them make the decision. You know, if they want to not come in for something, that's their decision. But that's my rule, 1 millimetre.
And the hypopion, is that
Yeah.
so? Why would they get that? Is that
So this is
yes, that's there. Yeah.
This is a hypopion here.
Yeah.
This is inside the eye, and it's a level. So it's basically loads of inflammation and stuff, just sinking to the bottom of the anterior chamber and just sitting there. That's a really bad sign usually. Up here, that's an ulcer,
Yeah.
whereas this is an abrasion, and you can imagine without the fluorescein that would be transparent. Whereas an ulcer, there's no fluorescein there, and you can see it clearly, and it's nice and round, like you said. This one here is a dendritic ulcer, so that's a cold sore in the eye basically. If they've had a history of trauma and the eye looks like this, then it could be a healing abrasion. Because it heals, sort of in sheets like that, so you can end up with something that looks like a dendritic ulcer. So don't worry if they've got a clear history of trauma and their eye looks like a dendritic ulcer, you can just treat it as an abrasion.
The one at the bottom left, what's that? What's that then?
That's a horrendous ulcer that looks like it's about to perforate with a hypopion, but you can get ulcers like this with a hypopion. And I'm guessing this is just over 1 millimetre, so that probably needs a scrape. So we numb it, take a needle, and just scratch the surface of all the mucky stuff, and put it onto agar plates, and send them off to the lab, and they grow it and see what antibiotics it's sensitive to. And we send also a plate for them to do microscopy on, and they can tell us what bug it is. So
when you send off the samples, do you start them on something empirical until the results are back?
Yeah. So usually a fluoroquinolone, something like moxifloxacin, ofloxacin, anything with floxacin. Here we only stock siloxane, which is ciprofloxacin drops, but the pharmacy have moxifloxacin, which is really good. That's 4th generation, and so you could prescribe that. And they can pick it up from the pharmacy. That's really effective for this. So yeah, this is the kind of ulcer you get in a contact lens wearer who's got a foreign body sensation for 3 days getting worse, that sort of thing. If you get this in a contact lens wearer, you mustn't presume it's a cold sore. This is where you start thinking acanthamoeba or something else nasty going on. Okay. Don't relax if you see contact lens. You just got to assume it's the worst basically, and I'd recommend picking up the phone for any ulcer anyway. But definitely if it's a contact lens ulcer. Any questions on ulcers?
That's good.
No,
That's good.
Okay, so yeah, small ulcer size, corneal scrape. We don't usually do them when they're under 1 millimetre because likelihood is that they'll get better with the drops. And we treat them with intensive topical antibiotics. So we usually ask them to have drops in every hour, day and night for 48 hours. So you usually get them followed up by someone else because they don't usually like you when you've started them on that. And you're basically marinating the eye in antibiotic, and you tell them you have to put an alarm on your phone every hour overnight. So I'm sure they don't do it, but that's in theory what they should be doing. And if after 48 hours they're better, then we start tapering it off hourly, just daytime, then 2 hourly, then 6 times a day. Gradually take them off. If they're not responding, then we admit them and we give them gentamicin drops and cefuroxime drops every hour. And the reason why you admit is so that the nurses put the drops in and you know they're going in. Because often the reason why it's not getting better is compliance with the treatment.
So when you admit people here, do they end up on which ward?
I think usually they fall under a surgery thing.
Because
Yes,
we always seem to bring them in under
But that
surgeons.
was a
Yeah.
man under
Yeah.
surgeons, the ophthalmic sympathy.
As an
I
emergency.
think the agreement, really depends on the hospital, but the agreement usually is if anything happens overnight that's not ophthalmic, then they call the surgical juniors. So if they're short of breath, they won't call us to come in, they'll call the SHO on nights for surgery. which is quite nice.
We'll then ask the medics to review.
Yeah, exactly. Yeah. But I've had it before where they've called me and then I've at 3 a.m. called the surgical SHO asking for a favour, which is not ideal, obviously. I haven't actually had to come in to assess someone medically before, but
if someone is getting admitted overnight, presumably the on-call reg is coming in to clerk them, or is it the surgical team clerk them?
no, we should clerk them from here. So if we know we're going to admit them, we should do a quick clerk-in.
We've got the surgical, you know the man with the
The squished eye.
Squished eye.
We've
The
had
surgical
the
team.
surgical team into
Yeah.
it.
Nice. Ophthalmologists don't have that reflex, to be honest. We're not used to admitting people.
Well, it's only because we found him again after he ran away from the clinic. We thought we could let him go.
That's well played. Yeah,
You managed to get hold on to him. Right.
yeah.
Sorry.
So we'd admit them, and if they're still not getting better, then you take a biopsy and see what is that bug that's doing this. But you can get stuck with these, the bad ones actually, because they don't respond to stuff sometimes. And sometimes you just need to cut the ulcer out and put a graft in. It can get quite bad. These, yeah. In low resource countries, there's a lot of blind people walking around with who have had ulcers, like simple little ulcers, who have then perforated the eye and they've lost the eye. So it's quite a common cause of blindness.
And would they wouldn't be at risk of their sympathetic?
Yeah, they would be.
They
yeah.
would be. Oh
Yeah.
my gosh.
Yeah. Do you know what synthetic ophthalmia is?
When something, a pathology in one eye, then
Yeah.
gets
Affects
moved in
the
the
other.
opposite eye.
Yeah, you can start getting uveitis, pan-uveitis, which means inflammation throughout the whole eye in the other eye. Just because there must be some antibodies and antigens going on in the bad eye, and because they're similar in the other eye, it sets those off.
Like an alternate.
Yeah, it's an autoimmune thing, yeah. Okay, and then large ulcers over a millimetre with a hypopium, we should come in and see them really. If you're referring these, you don't, if you say hypopium, they should come in. If they decide not to come in, that's their decision. I wouldn't worry too much about it. They should really come in for it. Don't say Alistair told me you should come in. Yeah. But I think they'll just be happy if you're measuring it, to be honest. And if you tell them it's 2 millimetres, that's good information for them. So, okay. So this is another case. 55-year-old punched in the face. I always find these people. They say I was minding my own business in a pub and they came from behind and hit me like that. It's never I was being a twat and it's always I don't know who he was. It's ridiculous. I'd actually like to do a study on that. Every patient who comes in who's been assaulted, how many of them claim that they actually knew the person or not?
Exactly.
I had one the other day actually, in fairness, and he admitted that he had done a kissing sign at someone else's girlfriend and then got punched. And I was like, fair play, at least he admitted it.
Yeah.
It's like, it's my fault. I was like, yeah, it was.
But usually the young guys, their mum's there as well, so they don't want to admit.
Exactly.
Yeah, the 24-year-old
Yeah.
mummy.
Anyway, he was punched in the face and in the right orbital region, and straight away developed significant swelling around the eye, and the eye was now shut. And this patient, we were worried about something called orbital compartment syndrome. Do you know what that is?
So compartment syndrome in the eye.
Yeah. So you're worried about bleeding behind the eye, and then obviously retrobulbar hemorrhage, and then that puts pressure on the eye. The eye can't push out of the orbit, obviously, because the dimensions don't fit. So then you get a lot of pressure on the eye. The pressure inside the eye goes really high. That's glaucoma, and it damages the nerve and blinds them. So that's orbital compartment syndrome, really. So they've had a big blow to the eye, a big punch, big trauma to the eye, and the eye's shut, and everything looks really swollen. So you can't tell whether they've got this problem or not. So what's your approach to this sort of patient?
Have they got any sight, VA?
So try and open the eye.
Try and open it.
So or if you don't manage to open the eye, all we come in and do is try harder and really force it. That's for examination, that's the only option we've got. And then you might only get glimpses. So you want to have your the thing that they're going to read at the ready. There's an app. There's a Snellen app. So I open it on my phone and just have that ready, like that.
How
And
far
then
away do you
open the eye. In this sort of case, you just want to see if they can see the E at the top.
Okay.
Yeah. There's a difference between them being able to see E and only being able to see light.
Yeah.
Okay.
So you just want to establish the vision. What else can you do when the eye's open like that?
Pupillary response.
Yeah. So what's a bad thing? What would be bad to see with the pupil?
Fixed dilated.
And non-reactive.
Non-reactive.
Yeah. An RAPD as well. So it might look normal, the pupil. Do you know how to test for an RAPD? Do you know what it stands for?
Swinging.
Swinging.
Yeah. You don't need to swing actually. You can just go straight.
Fair enough.
This is good. This is a good thing actually to know how to do. So it means
Compensatory
yes, it's relative to the other eye. So a fixed non-reactive pupil is an APD. Okay, an afferent pupillary defect. That means the message to the brain isn't going, so it just isn't reacting to light. Oh, my pen torches.
That's going to be really hard to do with a grossly swollen eye.
And the
Yes,
thing
yeah.
I've never known with the swinging gun
Swinging guns.
is surely, because when we do it, we're always doing direct and consensual.
Yeah.
Yeah.
Would it not just be picked up on the consensual because it wouldn't constrict?
No, because that would be an efferent defect.
Okay.
That's the message going back out from the brain to the pupil.
Okay, fine.
So you're looking for afferent, whether that eye is taking any messages in.
Yeah.
That's afferent. If this eye is taking the message in, the brain is sending to both eyes, that then becomes efferent. So you want to be directly testing the bad eye. Can't find my pencil. Does anybody have one?
It doesn't work very well. But, yeah.
I'll put that one.
Oh, here we go. What's this?
Temperament.
This looks like something.
Mine as well, exactly the same one. It's mine.
Dodgy. They all just.
You have to fiddle about the end of it, and sometimes it'll work.
Yeah.
Right, I've got a blue one. Oh, this is quite good for. I didn't know I had this. This is good for on the wards if you put fluorescein in, you can see. Oh, there's good one. Yes. Okay, so you're basically testing one eye relative to the other eye. So you shine on one side. So you go on the bad eye first, and it might constrict, which is fine. Then you know it's not an APD. And then you go directly to the good eye. Don't worry, we don't need to use it anyway. So you're on the bad eye, both have constricted. That's direct and consensual. Relax, don't swing, just go off both eyes and then go on to the good eye. That one should constrict, this one should constrict as well, that's direct and consensual. So you know that sort of stuff's working fine, and then you want to check them compared to each other. So if you're on the good eye, this one constricts, and then go straight across to the bad eye. If the signal isn't as good to the brain from this eye, it will dilate the pupil. It'll still be constricted on its own, but compared to the other eye, it'll dilate, and this one will dilate as well.
Okay, so it's just that it's holding the constriction with the retina.
Yeah, exactly. So in normal eyes, you go from one side, one constricts, this one constricts, you go to the other one, this one stays constricted, this one stays constricted.
Okay.
But in a bad eye, you go to this eye and it'll dilate a little bit just because it thinks the message is less strong, it thinks the light's less strong, so it dilates a bit more.
Okay, I see.
That's an RAPD.
Because I've always sort of thought, well, if you shone it in that eye and it's constricted, if you shone it in the other
Yeah.
one and it's constricted, then clearly but I get it now.
It's
the
it's
amount of
afferent that you're
constriction.
looking for, exactly. You can find good things on Google video, on YouTube showing you RAPDs. But that's a really useful thing to look for in a trauma. What other things can you see? When you're squeezing it open, what else might you want to catch a glimpse of?
If they've got a high fever, redness, I don't know.
Yeah. So if you have the slit lamp, you can see stuff like that.
Yeah.
If you're just eyeballing it, you can see.
Any sort of penetration.
Yeah, you can see if there's an obvious globe rupture.
Yeah.
So look at the white of the eye, see if there's any black stuff in the white of the eye. That can be the retina, basically. Altered blood can look a little bit black, obviously. So if it's been there for a while. But if you can see like blackish stuff, you've got to worry a little bit about a globe rupture.
Blackish stuff in the little sclera.
Yeah, so so there's been a rupture. It's been squashed so much that the sclera has ruptured a little bit, and you'll see a little bit of blackish stuff poking out there. Obviously, if there's a significant subconjunctival hemorrhage, the whole eye's red. That can also be a warning sign for a rupture. It can also be completely normal and benign, but you've got to be a little bit wary with those cases, especially if they're very boggy. If it's very boggy and commosed red conjunctiva, you've got to suspect a rupture. You can look at the pupil shape as well. If it's sort of pear dropped or mid dilated, that can just be from the shock, but it can also mean that there's a rupture and some of the iris has been sucked out through the cornea. So they're the sort of things you can check.
Okay.
If you can see on the slit lamp, then you just do your normal slit lamp examination as well.
You said high fever already.
Yeah, but at this stage, you're more worried about, has this patient got compartment syndrome, ocular motility as well, and proptosis. So can they move their eye? If there's a lot of blood behind it, they won't be able to move it much, and obviously if it's obviously pushed forward. So for compartment syndrome, vision's really important, pupil, proptosis, motility. If you can ask them to look at red as well. So you know, if anything red like the alcohol stuff, that red, or the drops, tropicamide drops are red.
Oh yeah.
You can get that out, and you cover one eye, and if the good eye, it should just look like a scarlet red, and then if you cover the good eye and make them look with the bad eye, if it's pinkish, that suggests that the nerve's not happy as well. So you're testing the optic nerve by checking the pupil and red. It's called red desaturation, that test. It's quite useful. So they're all signs for it, but I mean, what's the main thing that you're going to do in those sort of cases?
Presumably CT.
Yeah. So CT is great because you can't see the blood, but you can see the proptosis, and then you can also see if there's a globe rupture there. If it's not a nice sphere, if it's a bit squished somewhere, you can see. So that's usually what you do. The additional stuff that we would do is check the pressure. That's probably the extra thing, check the pressure, and you can also see if you can look at the optic nerve as well. But if the pressure's high, that also suggests that there's pressure on the eye. Okay, so examination, vision, proptosis, mobility, pupils, fundal check, investigations. Chest X-ray is not that useful because you can't see the eye, you can't see the actual globe, but it will tell you if there's a fracture. And if there's a fractured floor of the orbit, you can relax. There won't be orbital compartment syndrome because all the blood goes into the maxillary sinus, so you're fine. So actually a fracture is protective. But yeah, CT is the best thing to do. So this is quite an interesting one because you can see the proptosis here, clearly. You see that this one's further forward than this one. And also it's got a funny shape at the back.
Yeah.
Thank you.
And
cheers, well.
no, that's probably the eye being pushed so far forward with the nerve tugging it back and changing the shape, but it's probably also a globe rupture, to be honest, for it to change shape that much. But you know, that's a really bad looking scan. To be honest, this one would probably not have made it to the scanner. They would have had a procedure already by then. And do you know what that procedure is? Yeah. So if it's called lateral canthotomy and cantholysis. So if you've got enough signs, they've got a bad trauma, they're proptosed, they've got an RAPD, they've got red desaturation, they can't read much, the pressure's high in the eye, then you don't even need to do the scan. You need to do the canthotomy first, and then you can do a scan. So I don't expect you guys to do this one. It's just so you know that it exists. So it's a bit squished, the thing, but basically this is the nose is on this side. Yeah. This is the edge. Don't know why they're doing one on him. He looks alright.
He looks fine, doesn't it?
Maybe they'll do.
Whether he needs it or not.
So basically, you've got to imagine the two lids are like two ligaments here, and they both attach on the lateral canthus here. Okay. So first of all, you're separating the two ligaments by doing a snip here. So you're going in between the eye and the lids with one bit of the scissors and the other scissors on the outside, and you do a big snip there. And then you've separated the two ligaments, one above, one below. It usually bleeds like mad, that's quite impressive. And then you grab the lower lid, and that's skin here, but just underneath there you can imagine that it's still attached with like a ligament. And then you just put the scissors in there and cut it, and that loosens everything up, and it allows the eye to come forward you know, a few millimeters more and relieve some of the pressure on the eye, basically. There's not much evidence to say that you need to do the upper lid, but some people do it anyway. but you're basically releasing this lower lid, which is creating even more pressure on the eye itself. That's a bit of a clearer diagram. So you go between, you can see they've drawn as if there's ligaments there. So there's the upper lid, lower lid, and they come together. So first of all, you're separating them with the scissors, with a big cut. It doesn't look like that, but then you grab the lower lid and cut that bit. And then it's really loose when you do it, and that relieves a lot of pressure. So that's a sight-saving procedure that we occasionally do in A&E. I think I've done it twice in 5 years, so it's not very common. I think the first time I ever did it when I was ST1, I'm not sure if you needed it or not, but I did it anyway. You know, the thing is, there's no harm, you're not doing any harm with it, basically, and it heals on its own, actually.
You don't suture it.
No. So if in doubt, we tend to do it.
Can I grab a battery?
Sure. Any questions about this sort of thing? I think I was referred a case like this, that's why I brought it up actually, and they had a CT scan and things, and actually they were fine, but the person referring was worried about orbital compartment syndrome, but they didn't have any of those features, so it was fine. Okay, so 90-year-old lady, she woke up in the morning with a complete loss of vision in her right eye, and she had a background of hypertension and diabetes. So what's the top differential for total loss of vision in one eye?
Stroke.
Yeah? Stroke.
Yeah.
Where?
Posterior.
Brain?
Oh, this happened to a friend of mine. Oh, hang on. It's from the carotid where it goes up into the...
But then where's the, yeah.
I'm trying to
And
think where
then
the
where's the
occlusion
stroke?
was.
Posterior, isn't it? No?
So,
No, it's not. It's...
so if it's just in one eye,
Oh, it's at
In the
one eye.
where do you think?
Optic.
Optic.
Artery.
Optic artery.
Yeah. Okay, so it's central retinal artery or ophthalmic artery, yeah. So the key there is if it's, as you know, when the nerves come out of the eye, the optic nerves come out of the eye like this, and then they meet at the chiasm,
Yeah.
and then they split in two.
Yeah.
So if you've got a stroke in the brain, it's going to give you a homonymous hemianopia on one side, so both eyes are affected. But if it's wiped out just one eye and the other eye's fine, it's got to have happened in the nerve before it gets to the chiasm. So it's either the central retinal artery within the eye itself, or the ophthalmic artery which comes off the carotid, supplying the optic nerve within the orbit. It can't be brain, basically. So I asked this question later, but we'll do it now because I touched on it. But often these cases are referred and they've had a CT scan for their brain looking for a stroke, and they don't really need that. They need it if they've got a homonymous hemianopia. Do you know what that is? Obviously.
Yeah,
And often patients don't complain of a homonymous hemianopia. They'll say something like, "I'm missing stuff over here," if you're lucky, but most of the time they don't actually notice it. They're compensating. Somehow the brain doesn't realise it's missing that. But a central retinal artery occlusion, one eye goes completely, and that's it. So that's the top differential. Obviously other stuff can happen as well, but that's the one thing that needs to be ruled out, basically. Other things, central retinal vein occlusion, which is less serious for them generally, but that's a vein blockage instead of an artery blockage, so it doesn't count as a stroke really. Vitreous hemorrhage, if they're diabetic, can give them a total loss of vision if it's very dense. But the main thing is artery occlusion. That's the main thing to rule out. So what sort of questions do you ask with an artery occlusion or a total loss of vision?
I would ask if it was gradual or
Just,
like
yeah.
sudden. Had they had sort of for the last few days leading up? Have there been any change to their vision?
So what's worse?
Sudden.
Yeah. So gradual could be anything really, couldn't it? It could be a macular degeneration that's gradually getting worse, and then they've had a bad bleed from it, or diabetic, vitreous hemorrhage. It could be a cataract. And actually, sometimes sudden loss of vision is because they've wiped one eye and they've suddenly realised they've got whopping cataracts in the other eye. And they think it's sudden, but it's actually happened for ages. Sudden is bad. There's one condition which we always rule out with central retinal artery occlusion. Do you know what that is? So it's giant cell arteritis, temporal
okay.
arteritis. We always ask GCA symptoms: temporal headache, scalp tenderness, pain when they're brushing their hair, jaw claudication. A lot of people have jaw pain. Jaw claudication is eating and cramping pain that stops you eating, basically. It's very specific. A lot of people have neck pain, but you ask about that. Ask if they've got polymyalgia, night sweats, and weight loss. And the battery?
Yes, please. You're one of these ones.
I don't know how to take them out.
There's a little switch on it.
Okay.
Sorry. Thank you. Thank you very much. Cheers. Thanks, guys.
Yeah, night sweats and unintentional weight loss, and they'll go, "Oh, I wish." You have to ask about that. And then they always get an ESR and a CRP. That's the first thing we do with them, just to rule out. I don't think I've ever seen a GCA CRAO. We see a lot of CRAO, central retinal artery occlusions, but I haven't seen many with GCA. But you have to rule it out because it's life-threatening if they do have that. And you feel for their temporal artery as well. So it's up here, and you want to feel if it's pulsatile, which is a good thing, and whether it's specifically tender on the artery. So a lot of people go, ow, 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 that's fine, but if it's specifically on the artery, then that's not good.
With the vision loss in GCA, does it tend to be more sort of focal, or is it more general? So do they complain of sort of certain views, more sort of hemianopia type thing, or is it just general vision?
It can cause lots of different things with the eyes. So one, it can block the artery, because GCA is inflammation of the arteries, and they narrow with the inflammatory tissue and then shut off. So it can cause you a central retinal artery occlusion. It can also cause something called anterior ischemic optic neuropathy, which is sort of similar, but you can just lose the bottom half of your vision. And it can cause third nerve palsy, sixth nerve palsy, fourth, any sort of nerve palsy it can cause as well. That's the main way it presents as a CRAO, to be honest. It doesn't cause hemianopia.
And the symptoms are unilateral rather than bilateral? Okay.
You can get bilateral. We had a case in Brighton, they came in with one eye, and on their way up to the ward to have IV steroids, they got it in the other eye. And it was too late for either eye, really. So it can happen, and that's why it's so important to catch it.
Yeah.
Because they can also get heart attacks and strokes from the condition and die. So it's really important not to miss. It's a horrible one. It's one of the things I wouldn't like to have. Because you have to be on steroids for ages. So if you suspect it, ESR CRP whilst you're ringing us, that saves a lot of time for them, and urgent. You need it urgently.
So even if they come with those other symptoms of the...
If you've got a sudden loss of vision, I would do an ESR CRP.
Okay.
Even if it's vitreous hemorrhage and it's been a waste of money, it doesn't matter. At least you've covered yourself for the occasional patient where it will be a central retinal artery occlusion.
This is a dumb question. If they're there for CT scan of their head, what would show it's specifically being...
You can't see
it.
There's some MRI technology.
Okay.
But what we usually do, we send them for ESR CRP, and if it's clear cut, classic symptoms of GCA, and they've got raised ESR and CRP, we just treat them for it with 3 days of pulsed IV methylprednisolone, and then wean onto oral and refer straight to rheumatology. And rheumatology have a slot every Friday morning or every Monday morning for GCA, a new GCA referral. So they're quite accessible, actually.
But if they've got the central retinal vein occlusion, what would you see that on?
So the vein occlusion and the artery occlusion you can only see clinically by looking at the back of the eye.
Can't, so there's no point in filming.
Well, unless you practice looking, which is another thing we can do, because there's no reason why you can't practice doing that either, because it's actually easier than pressure, I think, actually. But yeah, there's not much you can do in terms of scans to diagnose it. No.
Fair enough. Okay.
Yeah, it's a shame. Okay. So yeah, that's one of the questions with artery occlusion you ask. You also want to ask if they've got diabetes, blood pressure problems, have they got any issues with atrial fibrillation or any known carotid disease. Because if it's not GCA, your next differential is an embolus, basically, either from the neck or the heart. So once we've got a normal ESR and CRP, then we would then refer them next to the TIA clinic for a workup, where they'll have an echo, a Doppler of their neck, a cardiac echo, maybe an ECG as well, just a general health checkup to see if there was an embolic cause for it. and what could you do in preparation was just me thinking you could do the ESR and the CRP, and you could also put a cannula in. Because if it is a CRAO, we might need to give them some treatment. So there are some, so these are the differentials. CRAO, retinal detachment can give you a sudden loss if it's sudden and severe. That's quite rare. Usually it's flashes and floaters and then a patch in their vision missing. But sometimes it just falls off quickly and they've lost their vision. Vitreous hemorrhage, CRVO. Okay, so questions you would ask, GCA symptoms, preceding episodes of amaurosis, so have they been having loss of vision lasting a minute or so and then it coming back? That can be a sign that a stroke was about to happen. It points you more in the stroke sort of field. Any other neurological symptoms is obviously helpful if they're about to have a stroke affecting them elsewhere. Then you want to ask them about microvascular risk factors like hypertension and diabetes, any previous strokes, TIAs, if they have AF, polymyalgia rheumatica, which is associated with GCA, and whether they're a smoker. So in preparation, you can check their blood pressure, because very high blood pressure can cause stroke, obviously. The cannula, and then you can send some bloods off. And then it's whether they need a scan or not. So they don't need a head CT if it's a monocular loss of vision. A lot of them get it. You know, there's no harm really, but it just saves you time. You don't need to do it. What was it? I saw one guy. I think the reason why I put this in was because the patient was referred from the medical ward with this sort of presentation, and he's had a CT. He was going to have an MRI next to look for the cause of the stroke, but actually it was all intraocular, the problem. So he didn't need all of those investigations really. Okay, so any idea how we treat central retinal artery occlusion?
No.
So it's basically untreatable. There's no evidence that any treatment works, but for some reason we throw everything at it, even though there's no evidence. It's really annoying actually, because you have to you get it referred, you're like, well, nothing's going to help you, but we'll try. So the main problem is the retina dies after 90 minutes when it's starved of oxygen, more or less. So usually it's happened overnight, or it happens that morning, they see their GP, then they come here, and then they see us. So it's too late usually. I'm sure if you catch them within 90 minutes, you could maybe help some of them. But you start from least to most invasive. First thing you can do is massage, a bit like an acute glaucoma. So you hold the eye, put pressure on the eye for 10 seconds, and then release. And if there's an embolus, you're hoping that the release of pressure that will then move it to a smaller arteriole and help them a little bit. You can also try Valsalva manoeuvre to try and increase the pressure. Non-rebreathe gets the CO2 flow and it causes vasodilation in the retina, so that can help as well. Then the reason why I mentioned cannula is we give them Diamox to lower the pressure in the eye to allow an embolus to pass more easily through the vessels. And then eventually we can do a thing called paracentesis, which is where you put a needle in the eye and release some of the fluid, and to lower the pressure as well. And usually I jump straight to this one because there's no evidence for any of this. If anything's going to work, this one's going to work. And I think if a lawyer's going to get me, if I haven't done this one, they'll pick me up on this. So that's what I usually jump straight to. I vaguely do a bit of that whilst I'm getting the needle out of the drawer, you know. And you basically want to end with that. Some people are the opposite. They'd never do that because the risk of them giving them an infection is high. And so I haven't really decided exactly how to treat this yet. But everyone has a different approach. But the key thing to know is that there's nothing that works really. I've never had anything that's worked. You get anecdotal stuff. So the main key for them is to rule out GCA and then refer them to the stroke clinic and make sure that they're not going to get another problem. And that's that for those.
Thank you.
Yeah.
Really interesting. Really interesting.
Thank you.
Thanks very much.
So a bit whistle stop.
But, can you send me that
Are you going to
pack?
send them?